oral and maxillofacial radiology. He has presented at numerous national and international symposiums and currently serves as assistant professor in the Department of Oral and Maxillofacial Surgery at Gandhara University, Peshawar. So Dr. Fahad is my senior when we were preparing for the exams, and there was, you know, thousands of messages I have sent to him, and he has replied to each one of them, and I am indebted for that experience for my lifetime. Dr. Fahad, the podium is yours. Thank you.
Thank you so much, Dr. Salan, for that very kind introduction. Bismillah ar-Rahman ar-Rahim. Thank you very much, everybody, for joining in today. And that was a wonderful presentation by Dr. Vishtab. I really enjoyed that. I hope this one lives up to that expectation. Traditionally, we should have had this topic yesterday, but unfortunately, I could not take out the time yesterday due to some personal commitments. So we're going to discuss this thing today, and that is the imaging of the temporomandibular joint. So whenever I do such talks like this, I usually like to start with the quotation, and I was having a really difficult time finding a good quotation to open this talk with. So I came across this book called Dot Head Poems by Amit Majmudar. And he had a very beautiful line about radiology in general, which goes something like this, that now picture a volume of a human reduced to planes and fluttering under my thumb like a flip book, showing the disease in action. So, if somebody is showing such reverence to radiology, you would guess that the author himself is a board certified radiologist himself. But the context here was that I think in TMJ, when I was preparing this talk, I came across so many things in imaging that I don't think I've come across such a variety of imaging options when it comes to any other disease process, just because of the sheer variety of the hard and soft tissues that you find in the temporomandibular joint. So, and because it's a joint, you can't see it. So you are very much reliant on your imaging to show you what's going on inside the joint, what the disease process or stage currently is, and what needs to be done in the future. So everything regarding the planning, everything is entirely imaging dependent. So the contents of today's talk is basically, firstly, we'll briefly discuss the purpose of imaging the temporomandibular joint, what are the various imaging techniques at our disposal, and what are the recommendations based on the American Association of Oral and Maxillofacial Radiology and American Association of Orofacial Pain. And lastly, I'll share a slide about the risk-benefit assessment of these various imaging options. So the purpose of imaging is threefold. You want to evaluate the soft tissue and the osseous components of the TMJ, both with regards to anatomy and function. So we're not just concerned about what are we seeing anatomy-wise. We also want to see what does the function basically cause, what changes does it cause in the joint with regards to the position of the disc as well as the movement of the condyle. So you have to evaluate all the components, both in static and in dynamic time. Secondly, our purpose is to evaluate the dentomaxillofacial region to identify any coexisting diseases and conditions that may contribute to the symptoms of the patient. Now, that can be because of any referred pain from the oral and maxillofacial region itself, or it can be because of some systemic diseases that may now be involving the temporomandibular joint. Thirdly, is that we want to evaluate the dentomaxillofacial region to identify any structural and functional consequences of the temporomandibular joint. So it's not being affected in isolation. There are reverberations of whatever is going on inside the joint throughout the oral and maxillofacial region. So it's very important that we identify what complications have arisen because of it. And lastly, we want to monitor the treatment outcomes. So we have to see that whatever we have prescribed or whatever surgical plan that we're doing, how is it going? Is it holding up? Is it not holding up? Is it staying the same? Is it getting worse? what is the status. So all these are the purposes of our imaging. So, like I said in the beginning, when I was preparing this talk, there was so many imaging techniques that I came across in several review papers, guidelines, and everything. And you would be wondering that do we have to order all of these for one single patient that we see? So, obviously, the answer is no. There are specific indications for each of these, which I'll discuss when I'm going through the recommendations which were given by those two associations. The one thing that I will here focus on, though, is that extraoral imaging techniques, with the exception of panoramic imaging, your transcranial, transpharyngeal views, which you may come across in the old books of maxillofacial radiology by White and Farrow. So these are considered obsolete in the current times. However, your lateral ceph and your frontal ceph, they still have a role to play when you're monitoring the disease progression, specifically in cases of condylar hyperplasia. Other than that, your other views are considered as immaterial in the current context. So usually, whenever I try to give such talks, since I don't consider myself an expert authority in anything actually, so I try to give evidence-based reviews so you can go counter-check these things instead of just quoting anecdotal evidence from me. Obviously, other seniors who are giving talks over here, they have a lot of experience to share, and their anecdotal evidence should be taken with a lot of thought and should be given its due weightage. However, I don't consider myself as such a person, so I try to rely more on sharing guidelines which can help us decide options. And I think that's the best way to go. So in this regard, I'm sharing a document which has been prepared both by the American Academy of Oral and Maxillofacial Radiology as well as the American Academy of Orofacial Pain. So you will find some overlap here between oral medicine and I would say oral and maxillofacial surgery. So that's because we have documents from two different bodies over here. So they have about, if I'm not wrong, about 9 recommendations that we'll be going through. So the first recommendation is regarding orofacial pain arising from odontogenic sources. So remember that whenever you get a patient with temporomandibular joint pain, so it's very likely that what you're having is could be referred from other areas of the oral and maxillofacial region. So their first recommendation for screening purposes was utilizing intraoral radiographs plus an OPG X-ray to evaluate patients with suspected odontogenic pain. And in complicated cases where you can't say anything for sure, a limited field of view CBCT scan may be required. So the rationale behind that was that you can go for either partial periapicals of specific quadrants of the mouth if you have a high index of suspicion that something is wrong over here, or you can go with a full mouth series of X-rays. However, for conditions like vertical and horizontal root fractures, where you're suspecting those, or internal and external resorptions, probably in those cases, your limited view or a dentoalveolar CBCT would be much better and useful in this regard. So, if you want detailed recommendations regarding those, both the American Association of Endodontics and the American Association of Oral and Maxillofacial Radiology issued a joint position statement on this in 2025. It's an open access document. You can go through that and you can have more detailed information from there if you like. So, like if you see over here, vertical, horizontal root fractures, you may be able to diagnose if you take two periapical X-rays at different views. But vertical fractures, root fractures are very tricky to get. And unless maybe if you have a very good endodontist with you and a good operating microscope, I don't think you're going to diagnose them very easily. So you can see over here, we have a CBCT an axial view showing a vertical fracture over here. And other teeth, you can see it's not really visible. You don't get this view with any periapical X-ray. So this probably you'll be missing it when the diagnosis comes. Similarly, for internal resorption, I would say, again, in my very limited experience, and I'm not an endodontist, but you might be able to catch such lesions, especially when they get quite as big as this. You should be able to see them on periapical X-rays. However, for external resorption, if you see a periapical over here, now you might say that, yeah, there's a bit of PDL widening over here, but really maybe other than that, you can't really say much what's going on. But when you order a CBCT, you can see that there's extensive bone loss, loss of the lamina dura, as well as cementum resorption you can see over here. And in other views, here's a sagittal view over here and an axial view over here. So you see quite a big lesion which has extended to involve the adjacent premolar as well. In such cases, probably it's better to go for a CBCT if your diagnosis is a little bit in doubt. In addition to this, two things which I found in my practice, which I'd like to share, is that always evaluate the styloid processes whenever you order an OPG in such patients, because you will find literature supporting this that styloid processes are on average much lengthier in patients with temporomandibular joint disorders as compared to the normal population. So, on average, I would say normal, if you go through literature, styloid processes should range in between 20 to 30 millimeters or 2 to 3 centimeters. So if they're longer than that, you should consider that as a differential in your when managing such cases. So Eagle syndrome, which it is called, or styalgia by I've noted a few of my ENT colleagues calling it that. So that can also be a cause of the referred pain and may have nothing to do with the joint in itself. In addition, I had a case recently where we had a patient who was giving us a history that I have some pain in my temporomandibular joint, and however, he was not giving a very specific history. So they had a similar X-ray to this, barring the elongated styloids. And when my registrar showed it to me, I said, "Is the patient localizing his pain to the upper jaw by any chance?" She said no, but I'll check anyway. So she said, yeah, he is localizing it to his upper jaw. So what do you think it is? I told her that I see an impacted upper third molar. It looks to be similar sort of depth which you see in this X-ray. So I just told her to do some periodontal probing distal to the upper seven and see how deep this probe is going. And once she did that, the probing depth was in excess of 5 to 6 millimeters, which is larger than your normal 3 millimeter cutoff. So then I told the patient that, it's not your TMD pain and it's probably your upper eight, which you need to remove. However, patient was not willing for removal at that time due to some family events taking place. So if and when she comes back, maybe I'll share that somewhere and we can learn more from that. Now, coming to the second recommendation, that was regarding arthritic diseases of the TMJ. So, most commonly, you have osteoarthritis, and among the systemic diseases, you can come across conditions like rheumatoid arthritis and psoriatic arthritis. So, the recommendation for such cases is that you don't rely on your OPGs and you should go directly towards multi-detector CT imaging or CBCT, which is more widely available in dental hospitals. So they should be used to evaluate osseous changes in patients with suspected TMJ arthritis. Panoramic radiography has a limited role in establishing arthritic changes because the anterior aspect of the condyle is one area which is not really captured well on OPGs. Plus, you have a lot of overlap from the zygomatic arch and the temporal bone in such cases. So probably that will hide a lot of the changes which are occurring over there. So a lot of times I see such patients, they have this condition which you are seeing over here. So this is called as anterior beaking of the condyle, and now this can be active, this can be static, so it's not an indication of a severity of the disease. Rather, it just signifies that the patient does have some amount of osteoarthritis has taken place. So it's more important to evaluate what the patient's symptoms are at that time. So, like I said, there is low sensitivity, low specificity of the OPG and the established clinical criteria for diagnosing TMDs or arthritic conditions based on just those criteria, just 50 to 60%. It means you're going to miss about 40 to 50% of patients who do come to you with such problems. In addition, on OPGs, there is about 10 to 30% sensitivity for diagnosing osteophytes, erosions, flattening of the articular surfaces, and subchondral cysts. So that is very low. It means you are missing out on a lot of clinical features which you would see with advanced imaging options. So there will be disagreement between two different people who read an X-ray. You should take that into consideration as well. So between CT and CBCT, obviously CBCT has a lower radiation dose. So probably that's why you can recommend CBCT as the first line imaging when you see a patient with suspected TMJ arthritis. Now, coming to third recommendation, and this has a lot of material in it. So I'll be discussing a few things separately in this. This was regarding developmental disorders, condyle aplasia, hypoplasia, hyperplasia, and hyperplasia. So you can use your OPG X-rays for the initial radiological assessment or screening for such a disorder. However, if you are planning for surgery or you want to do some pre and post-operative analysis of the TMJ complex, you should definitely go for CBCT in such cases. So the rationale being is that it's very good for identifying all of these changes, which I just mentioned previously in the arthritis section. And if you are not planning any surgery, you can go till OPG and then you don't need to upscale and go towards the CBCT because you're not planning anything surgical. If you are planning surgery for such a patient, then CT or CBCT is very good in such cases. There it has about 70 to 100% detection rate, 70 to 80% sensitivity and specificity for diagnosing osseous changes as a result of this. Now, I'll put a little bit of local context onto it, that what sort of disorders do we see which come in this category of patients. So, TMJ ankylosis is very common in our part of the world, and for TMJ ankylosis, question came up yesterday as well, which was answered. However, I'll raise it up again over here, that in cases of TMJ ankylosis, it's always best that we do go for a CT because an OPG will not tell you about the medial extension of the ankylotic mass and more importantly, the relationship of the maxillary artery. So the question does arise, do we need to go for a CT angio in all cases of temporomandibular joint ankylosis? So based on the literature, I found about 3, 4 indications where you should go for a CT angio in patients of temporomandibular joint ankylosis. Number one is extensive medial growth of the ankylotic mass, its proximity to the foramen spinosum. In addition, if you can clearly see the maxillary artery, a tubular structure which is closely abutting this ankylotic mass, that is another indication. If you have a patient who has recurrent ankylosis, so there's a the high likelihood that such patient would have entrapped the ankylotic mass would have entrapped the maxillary artery, or it would be in close proximity to it. So in these 4, 5 cases, it's very important that you do definitely go for ordering a CT angio in such cases. Because I still remember when I was in training, our supervisors used to call the maxillary artery as the auntie. And the auntie here signifies that troublesome relative you have on family dinners whose job is just to create chaos and, family drama for no reason whatsoever. And the maxillary artery is going to create drama in the form of bleeding that you may or may not be able to control. So in such cases, specifically for ankylosis, it's probably if you meet any of these 3, 4 criterias, you should definitely order a CT angio in such cases. Now, nuclear imaging also has a role here, and this was a systematic review published in 2026 very recently regarding the use of nuclear imaging in temporomandibular joint disorders, specifically regarding arthralgia and condylar hyperplasia. So traditionally, what I've personally seen in my training is that we have bone scintigraphy, which is also called as planar 2D imaging. So you can see the sensitivity and specificity values over here. They're all right, I suppose. But if you want to level up and get a better idea of what the problems are over here, it's better to go for a SPECT. So SPECT and your bone scintigraphy both utilize the same tracer. It's technetium 99, but the main difference is in the gamma camera that they use to get those images. So in 2D imaging, they just take pictures from two angles of the patient and inspect. You have a 360-degree rotating gamma camera, which takes better images, gives you better sense of the anatomy over here. The problem with both of these imaging is that it does not really localize the anatomy very well. It just tells you which area is taking up the tracer a lot. So in such cases, you will see SPECT being combined with CT imaging, and here you can see that the sensitivity is picking up by quite a lot, and as well as the specificity. So it's a borderline expensive treatment investigation to order privately. I've asked around over here, and the cost is about between 10 to 20,000, 10, 15,000 in the public sector hospitals, and maybe 19 to 20,000 in the private sector hospitals. So when you're ordering it, you should really have a really good reason for ordering it, because you have to take into the consideration the socioeconomics of the place that you're working in. So for condylar hyperplasia, which was discussed very nicely yesterday by Dr. Armagan, I really enjoyed his lecture yesterday. I came across two, three things which I thought a lot of people were asking and were asked today as well. So I'll just maybe repeat them just for repetition's sake for those anybody who hasn't taken the lecture. So for condylar hyperplasia, when do we diagnose it based on SPECT? So condylar uptake of at least 55% or a difference of 10% between both sides is considered as signs of active unilateral condylar hyperplasia, and values between a 5 to 10% difference is an indication of possible condylar hyperplasia. So the guideline group recommends that in the first instance, you monitor it via a SPECT if your SPECT is borderline. So the cutoff is defined as uptake of at least 55% or a difference between condylar values of at least 10% and unremarkable clinical findings. So if you do come across a difference between the two condyles, what do you do? So then you should what we've heard or what we were taught for a long while is that you just order clinical pictures, or you just tell the patient, come back after every 2 to 3 months and we'll repeat your lateral cephs x-rays and we'll see what's going on. So those x-rays are not going to pick up the changes very quickly. So it's again recommended you either order a spiral CT or a cone beam CT at an interval of 6 months to compare the condylar and occlusal changes. So if there is a difference in the condylar height or diameter between the two condyles of at least 5% at two consecutive follow-up examinations, so then the condyle is deemed to be at an active phase. And the speaker before said, probably it's then best to either wait, either you go for a high condylectomy or see till the burnout has occurred for at least a year, and then you go for reconstruction of the joint. So these are not things that I'm saying by myself. These are based on the two guidelines I've quoted over here. So you can go through them again if you want, and let's see. So this is what basically a SPECT would look like. The SPECT I noted in our registrations, we have some undergraduates and fresh dental graduates here as well. So for your sake, I'll just try to keep it as simple as possible. So SPECT basically stands for single photon emission computed tomography. And over here, you can have a rough idea that you are probably looking at the vertebra over here, and this is the rest of the skull over here. And these two areas, these are basically your condyles. So if you compare, let's suppose in this image over here, you can note if you look at it for about a few seconds that this condyle over here appears to be a lot more darker than this condyle over here. So that would signify that the right condyle is showing a lot more tracer uptake. So based on this, how are you going to calculate those percentages that you need to calculate whether there is actual active growth taking place there or not? So what we do is that now we have the facility of combining your specs with conventional CT. So in this case, now you can appreciate it a lot more that the right condyle is showing a lot more signs of growth as compared to the left one. So areas where you're getting a lot of orange is basically showing active areas of remodeling and high areas of tracer uptake. So you can see in the left one, there's not really a lot of orange in the center, but over here you can get a lot, you are seeing a lot of orange over here. So it means that active growth is currently going on. So this is what a SPECT CT would look like. And interestingly, this was actually a question in my FCPS Part 2 paper at the time when we had an SEQ pattern. So this is something that's very close to my heart for not very good reasons, I would say for traumatic reasons. Anyhow, so moving on to our fourth recommendation, and that is for assessment of internal derangement, what should we do? So internal derangement, your disorders like disc displacement with reduction, without reduction, all of these come into play. So for these cases, if you have a patient who is not responding to conservative therapy for about maybe 4 to 6 weeks or 3 months, and you have some atypical presentation, or you figure that by ordering an MRI or imaging, your treatment plan may change. Or if you just want to get a baseline that what is the status of the joint, because a lot of these times these patients are chronic patients. They are not very patients who come with very small, short histories. They come with very long histories. So in my practice, I do order at least an MRI once in their life at the very least, unless the condition is deteriorating fast. So I would recommend you guys do the same as well. So the sequences that you should order of the MRI are your proton density or your T1 weighted images along with T2, both in the open and closed mouth position. So that'll tell you whether the disc is getting displaced, is it getting caught up again with the condyle when the movement opening is occurring or not. In addition, the T2 weighted image will also show you some effusion if there is any excessive inflammation going on, which is not responding to your conservative therapy, or it is more than the joint space can accommodate. So that's something you can only an MRI can tell you, no other imaging study can show you. So you can see over here, this is the condyle, and you have this blackish structure that you see. This is the disc. Here you can even see the lateral pterygoid muscle inserting into the neck of the condyle. This is the closed mouth position. This is the external acoustic meatus over here. This is your brain. This is the articular eminence. And now in open mouth position, you can see this is the glenoid fossa. So now the disc is again, this is normal TMJ. So don't expect to see any pathology over here. But this is black structure. This is your articular disc. And now you're seeing that it has come almost at the level of the articular eminence, and it is on top of the condyle as it should be. So the rationale for it is that your clinical assessment again is not has its deficiencies. That's why it's better to go for an MRI at least once. And the location and the shape of the disc is something you can only see on an MRI. No other imaging modality will tell you what the disc looks like. Arthroscopy is definitely better because MRI is not very good at picking up disc perforations. That is something only an arthroscopy can tell you. But again, it's an invasive procedure, and availability of arthroscopes as well as the expertise of the surgeon, that are also factors to note. And regarding effusion, like I said, no other imaging modality will tell you that other than your MRIs. So, in this case, I would like to bring up the role of ultrasound. Although the ultrasound has only been used for TMDs in the past 10 years, and when I asked a couple of my radiology colleagues, they said none of us are doing ultrasounds for temporomandibular joint disorders. And the reason is that because you have two bony structures over here, your articular eminence, your temporal bone, as well as the mandibular condyle. And ultrasound really doesn't tell you a lot about bone. So you only can see a little bit of the disc, not all of it, just its lateral aspect. So, and because of that, its sensitivity is varying a lot, 69 to 74%. So that's, I would say, a little bit on the low side. But the problem actually comes with its specificity, very broad range. So you can miss a lot in such cases. So this is not really why it's probably the first line. So, a review about the role of ultrasound came out about a few years ago. It's considered as valuable for initial screening, but not for the final diagnosis. So, Advantages regarding it over MRI is it's more cheaply available. You have to take into account again the socioeconomics of your patient population. So in that regard, it's quite good. Less time consuming, no issue of claustrophobia or anything else, or keeping the mouth in open mouth position for a long time, which happens regarding some MRI sequences. But again, the accuracy of it and specificity of it is something that needs a lot more work. So maybe in the future, but currently, MRI is the king regarding internal joint evaluation. So coming to regarding recommendation number 5 for assessment of trauma of the temporomandibular joint, well, it's hardly a surprise that although you can use an OPG X-ray for the initial imaging examination for a patient with trauma, but CBCT imaging with 3D reconstruction can evaluate the patient far better with known and suspected fractures of the mandibular condyle. So, as compared to OPG, OPG has a sensitivity of about 70% for detecting condylar fractures, CBCT in the high 90s. Plus, for detecting non-displaced fractures, CBCT is much, much more accurate. Plus, whenever you have a fracture of the condyle, there's a high chance there's going to be a fracture somewhere else in the mandible as well. So, OPG is just good. Probably, I would say, does not really screen the parasymphysis symphysis area very well. So, again, CBCT is much better in this regard. Again, if you want more detailed information on why we go for 3D or CT imaging, so I would recommend the American College of Radiology criteria for imaging of facial trauma following the primary survey. It came out in 2021, and it will cover the rest of the fractures as well. But you can read it. It's a very interesting and very educative document. Now, coming to recommendation 6 and 7, that is regarding assessment of cysts and neoplasms in the TMJ area. So, CT imaging should be done to evaluate patients with known or suspected cysts and benign tumors in the TMJ region. Cysts are very rare. Ganglion cysts and synovial cysts have been reported in the literature. Personally, never came across them in my life. I have, though, come across a couple of maybe benign tumors. You can come across an osteoma and osteochondroma in such cases. Uh, and whenever you have cysts, it's better to go for an MRI. You can see over here. This is a picture of basically a synovial cyst in the temporomandibular joint itself. So this is a T2 sequence. That's why it's appearing hyperintense to you. This is the T1 sequence over here. And on T1, remember, pathology is often hypointense, so that's why it's appearing dark. So in most of the cases, TMJ cysts that you'll see will be of the surrounding structures which are extending into the TMJ, and intra-articular cysts of the TMJ by itself are quite rare. Now, regarding malignancy, CT and MRI should be done for such cases, and you cannot just rely on plain X-ray. So the rationale is that high sensitivity, specificity for of such modalities for detecting malignancies, and if you want to evaluate the soft tissue, so CT with contrast may be somewhat helpful, but if you want to take it a step further, you want to evaluate the soft tissue in itself, any perineural invasion, if that is occurring, any spread to the base of the skull. So that can only happen on an MRI, and that's not something you'll be able to appreciate on any other imaging modalities. So the risk benefit assessment, this was given by the author of the guideline which I've shared today. And this is again by Sanjay Malia. And if any of you have come across the latest edition of White and Farrow's Oral and Maxillofacial Radiology, well, the latest edition was authored by Sanjay Malia himself. So he put in a table regarding other X-rays for evaluating different areas of the maxillofacial region, and I'm not surprised he put in a very good table which summarized the use and the utility as well as the radiation exposure of all these modalities regarding all these different for just summarizing the content of the guideline. So you can see that intraoral, like I've said, it's wherever it's the utility is high, they've given two pluses. Where the utility is low, they've given a single plus. And the radiation exposure obviously has been reported here with this double forward sign. And with regards to MRI, you can see that there is no radiation exposure because it's not a radiation dependent imaging modality.
Dr.
So
Fahad,
this
you
is
have two
the
more
guideline that
minutes.
I shared over here. Uh, Dr. Saran, were you saying something?
Yes, I was saying you have 2 to 3 more minutes for the presentation. Then we
Yeah,
have
I'm
to
done.
move to the
I'm almost
questions.
done. I'm
Oh,
almost
great.
done.
Thank you. Thank you.
So, this is the paper on which I've based today's presentation, recommendations for imaging of the temporomandibular joint, position statement from the American Academy of Oral and Maxillofacial Radiology and the American Academy of Orofacial Pain. So it's open access. You can go through much more detail than I was able to give because obviously the time duration of today's talk. So please do go through it. It's a wonderfully educative document and I hope you enjoy reading it. So thank you very much for bearing me. And if there are any questions, I would love to take them.
Thank you so very much, Dr. Fahad, for the wonderful presentation. So we are open for the questions for Dr. Fahad. Then we will move to another speaker. So you guys can just type your question in the chat box. Thank you. We have 5 minutes of questions and answers.
Okay. So in patients with TMJ disorders, imaging findings and clinical symptoms don't always correlate. When there is a mismatch between the two, which one do you prefer planning treatment, the clinical examination or the imaging? A very good question, Hamad. And I would say is that especially in the context of a patient where you have, let's suppose you have a patient who presents to you with TMJ pain and you diagnose it as let's suppose as a myofascial pain. You order an X-ray and you see a lot of the anterior beaking of the condyle, which I just showed to you earlier. So, like I said, the beaking of the condyle is not does not signify what the severity of the disease is currently. So there can always be a mismatch between the clinical and the radiological. So based on the patient's symptoms, I would say that would dictate what the treatment needs to be, and obviously that would guide the treatment instead of because you're not treating the X-ray. I love this quote by Dr. Bakhtawar yesterday when she said that you're treating the patient, you're not treating the X-ray. So go on what the patient's complaint is and try your best in trying to evaluate that. Sir has asked a question, sir. Thank you very much for your feedback. For evaluating the health of the disc, I always try to go for an MRI. Unfortunately, as part of our training, we never ordered MRIs for such patient. We just used to rely on OPGs. And it was once we graduated, we completed our residencies, got our qualifications, we said, no, we need to try at least to order MRIs for our patient and see how things go. So the limiting factor here, although still is that TMJ surgery is not very well developed. At least I would say in KP, it's not very well developed at the in our province, but I'm not sure about the rest of the country. But even if we do come across such things, if we come across a very compromised disc on the MRI, we are still very hesitant in openly operating that, doing open surgery of the TMJ. So I would definitely go for an MRI. It is available in public sector hospitals, so and does not really require a contrast. So I would say about it. You can do it here in locally 4 or 5 thousand rupees in Pakistan. I'm not sure about abroad. So I think if it's possible, patient can afford it. Why not? Definitely should be done. All right. So thank you, Dr. Qasim, for I hope I'm very glad I could answer your questions. So yes, experience will guide you. And addition, I would like to add a quote by one of my ENT supervisors. He used to say there needs to be an alignment between your clinical features, patient's history, and imaging, and that should guide your treatment, whatever you want to do instead of again just treating the X-ray and whatever you find on the X-ray. So I hope that answers that. For patients undergoing TMG surgery or total joint replacement, what imaging features are absolutely essential for preoperative planning? I think Dr. Vishtab would probably answer this much better since I don't have any experience of ever seeing total joint replacement or open TMJ surgery. In such cases, all the cases that I've seen are predominantly related to temporomandibular joint ankylosis, for which I think we already know a lot. So probably I would refer Sir to answer that question. Um, for condylar hyperplasia, how frequently can the CBCT be reported to see if the active disease has stopped? Can OPG be used for the same purpose? No, OPG, like I said, has low sensitivity and specificity in diagnosing the changes which are happening, and there is a significant overlap of the surrounding anatomical structures. So I would not recommend an OPG. You can do a CBCT. You can do a limited field of view CBCT to see if the active disease has stopped or not based on the diameter parameters, which I just stated, 5 to 10% change in over 6 months. So you can use that for that. I would not recommend an OPG for this purpose. You can do a CBCT as regularly as you want. However, the diagnostic yield has to be specific. So I would say about you can do it maybe every 3 to 6 months to see how things are going in this regard. Uh, do I see any role of artificial intelligence improving the diagnosis and grading of TMJ disorders? Yes, I think I came across one AI app which was related to pertaining to OPG called OPG Genius. So that was grading that was mostly concerned with diagnosing odontogenic causes, evaluating caries, any pockets, anything like that. But yeah, why not? I think they can definitely do grading and of diagnosis of temporomandibular joint disorders, not just on OPGs, but on CBCTs as well. So machine learning would be a very important step in this, in any AI project. You will have to have at least, I would say, 3,000, 4,000 CBCTs in order for the machine to, the AI engine to properly grasp the concept of diagnosing the change and then obviously diagnosing it itself. Which MRI findings help distinguish between ICR from inflammatory arthropathies or advanced osteoarthritis? Well, for inflammatory arthropathies, specifically like rheumatoid arthritis and osteoarthritis, the main differentiating factor is the thickness of the synovium. So that you can only appreciate on an MRI. You will not come across synovial thickening in osteoarthritis, but in rheumatoid, you will definitely come across it. So you should evaluate the synovium thickness in the coronal view of the condyle, and hopefully you should be able to uh, uh, get a good idea from that. I always get a CBCT and MRI for the TGI. Wonderful, sir. So I think that answers the question for Dr. Sana. What are the big and straightforward signs that a general dentist could see in OPG for timely referral? I would actually recommend that you don't go for OPGs in such case. Like I said, the changes in OPG take a lot of time to manifest, and it's highly likely that you will miss the very initial stages of the disease where you can probably catch it quicker, treat it better. So I would say that don't rely on OPGs. If you are seeing something which is not responding to conservative therapy within 4 to 6 weeks, and the patient's pain is not improving, the function, range of motion is not improving, I think you should definitely go for CBCT or an MRI, depending on what you're suspecting that the patient has. Uh, I'm not sure if Dr. Qasim is asking me the question over here or if it's for Sir Vishtab, that if I order an MRI before and after, and what is the rationale? I think that's probably for Sir. So let's see what Sir answers regarding that. Yeah, do we have any more questions?
Thank you so much, Dr. Fahad, for your detailed presentation and answering all the queries. We have learned a lot from you in the past, learning now,
Thank you very
and
much. Thank you very
and in the
much.
future as well. Thank you so much for your time. You are more than welcome to continue in this session.
Actually, I haven't eaten and I'm really starving. So I'll
Okay,
catch you guys up after a little while.
okay, okay. Have your dinner. Thank you so much. So, without
Thank you
wasting the
so much.
time, uh, we should move to our next presenter. I think Professor Dr. Dimitri